further ado, I'd like to welcome the first speaker. So the first speaker is Dr. Charles Roberts, who is co-founder of Freenome and Chief Partnerships Officer. And he will be giving us a presentation on, quite a mouthful, applying advanced machine learning techniques to develop non-invasive blood tests to detect early-stage cancer and improve precision oncology. If any of you have read Bad Blood, this is a very topical conversation. Without further ado, welcome Charles to the stage.
Thank you. Afternoon, everyone. Is this about the right level of loud? Thanks for your attention. So I didn't come up with that long title. That was our marketing department, amazingly. But it says kind of what I'd like to get across. I'm going to come up with a simpler title, which is actually what I want to talk to you about is tests that learn. So I was a doctor in the UK NHS, actually most recently in the Royal Marsden, which is where I became really passionate about early detection. One of the things that we constantly saw were people coming in tragically, had we seen them 2-3 years before, we knew that we could have done a resection and that person probably would have lived. And in this case, they probably weren't. So that was really when my personal mission to do early detection really kicked in. We founded Freenome about 4 years ago with really a vision of helping patients by achieving early detection of cancer using machine learning. And I'll talk a bit more about how and why we would do that. So we think about Freenome as bridging early detection and early intervention. What we mean by that really is capturing cancer earlier, and I'll talk a bit more about that, as well as actually then giving an insight into the right treatment course and some prognostication about what might happen next. And we're now working with QIAGEN as a platform partner on some of those questions. So here are a few stats on the company. So we're a startup. We're based in San Francisco. So now I'm in San Francisco. I've got a lot more geeky, started reasonably geeky. So I've got much more into numbers. And to check people are awake in the afternoon session, I will ask a couple of random number quiz things. But anyway, company by the numbers. We're about 80 people. We raised about 72 million in financing, total of 78 in a large Series A last year. We've amassed about 10,000 proprietary data sets, mainly whole genome actually sequencing from blood. And that's taking samples from our about 45 clinical partners, including some leading names you'd know, like Oxford, UCSF, and so on. And we've now got 9, I think, biopharma partnerships, which are revenue making. And from them, we're receiving samples, mainly from phase 2 trials. And their goal is really around early detection, but through to companion diagnostics and biomarker discovery. So I want to arrange the talk in sort of 3 main sections. The first will be just to look at early detection and say, why would we even want to do that? Is that a good idea? Secondly, I'm going to talk a bit about the biology and why we choose to do what we do and why it's so hard. And thirdly, why AI comes in and how that's helpful. So really the benefits of early detection for many indications are becoming quite clear. To draw your attention, for instance, to the center of that graph in colorectal cancer, you can have about a 6x better outcome at 5 years in terms of survival by detecting cancer at a pre-metastatic stage when it's localized, or at a metastatic stage, the survival is really very, very low. And even at the right-hand side of that graph, you can see some of those other conditions like bladder and lung and liver. You can actually get a 10x or more advantage from discovering the cancer at a pre-metastatic stage. So an important thing to do. However, the traditional screening methods, which rely on traditional technologies, really are not good enough. So you'll know many of these. They rely on things like single blood markers, like the protein for PSA, and actually visualizing the tumor, which can be even harder in things like mammography and other scans, as well as colonoscopy, which is actually a very good test, but it has poor adoption because it has risks and people don't want to get it done. In fact, one of my co-founders, who's a long way shy of 50, thinks that one of the main reasons he's in the company is to try and race towards not having his colonoscopy when he is 50, and he can ignore that letter. And the other problem that's big issue with these tests is they actually get worse over time, and that's exactly what's been seen. Partly because they're too simple, like PSA, and they're just one marker, and they just don't take account of the complexity of the condition. And also because a lot of these tests were developed in a sort of idealized population, and they didn't take account of what would happen in the wild when these tests were deployed, and you've got lots of edge cases and lots of complex clinical histories. And actually we've seen the sensitivity and specificity of all of these tests come down. And just for sort of recap, anyone that doesn't deal with diagnostics on a daily basis, sensitivity is what proportion of the true conditions are detected by the test. So 90% sensitive means you're detecting 90% and missing 10%. Specificity is the other way around. It's of the of the positives, which proportion are true positive. So an 80% specificity means you're falsely saying yes 20% of the time, if that sort of makes sense. And to pick up specifically on colorectal cancer, because that's somewhere we're very focused, and we just announced a large, like a 3,000 patient prospective study. The benefit of early detection is very large indeed. And actually, if you can detect the precondition, advanced adenoma, which is really an adenoma of a centimetre or more, you can almost always affect a cure, which is something we're really, really shooting for. Because at the moment, colorectal cancer is still a major cause of suffering. So, sort of by the numbers again, in the US alone, a third of people are not current with their screening. And partly as a result of that, partly as a result of bad screening tests, and partly as a result of poor treatments, something like 150 new cases are diagnosed a year, roughly, 150,000, which is 16 every hour. And roughly 40 to 50,000 people will die every year from colorectal cancer. And some of that is avoidable. And that makes it the second largest cause of cancer-related death. So on to solutions, a bit more positively. So how are we approaching this and why? Well, one area of innovation that Freenome is working on is lab innovation. So because it's a very complex multifactorial problem, and that applies to whether you're just trying to detect colorectal cancer, or in the long run where we would like to have the same data sets growing for all patients and actually detect multiple cancers, so add on tests for breast and lung and liver and so on. So we're doing a lot of innovation in the lab around robotics to make sure that you can do multi-analyte robotic preparation, which is extremely hard, and do it simultaneously and in parallel. And I'll come more into that in a minute. Then we're using AI, or more properly we should say machine learning, to understand both each individual of those analytes and actually subparts of those analytes, and then to integrate the information from those analytes and turn it into one consistent answer at the end, which is no mean feat, as you can imagine. And then really thinking into the future about how do we make that a dynamic test that can work through time. And that's really, I'll talk a bit more about that, but that's where we get onto this idea of tests that learn. So then just to get onto the section talking really about the biology. So, okay, my first geeky number. Does anyone know how many cells are in a human? Roughly. Plus or minus a trillion. It's about 40 trillion is the sort of best estimates. And the amazing thing about that is obviously that all came from one cell, driven by epigenetic pathway selection to ultimate differentiation. And actually between 100 billion and a trillion cells, but mainly white blood cells, die every day in every human. So it's a huge amount of disgorging of cellular material into the blood. And the nuclear content, so including the cell-free DNA, the RNA and everything, goes into the blood where it starts getting chewed up and destroyed. And part of the signal we pick up is actually, and I'll come more into this, the characteristic fragmentation of those cell-free DNA fragments in the blood, and what we can then learn about the gene expression profile of the cells that release them. Something quite non-trivial that a human would really struggle with, and I'll come more into the AI in a minute. So the other problem is in an early cancer setting, which is when you really want to pick it up, the amount of tumor contribution to that cell-free DNA in the blood is very, very minimal. It's actually about 0.1% at stage 1, which is a true needle in a haystack problem. So the Freenome solution is to actually say, well, let's not look in the haystack. Let's look at the entire haystack and step back and say, what disruption has occurred to that haystack as a result of the needle being there in the first place, as in the person having cancer. And what we mean by that, to continue the sort of philosophy on it, is even if you look in the tumor itself, mutation-carrying cells make up actually a small proportion of the volume of that bulk. It's mostly stroma, like cancer-associated fibroblasts, and immune cells which have gone there to fight the tumor. So it's this very active microenvironment with this battle going on between the body and the tumor. And so actually trying to understand how we can find that host response is very, very important to what we do. So to sort of flip to another analogy, we think that the signal from the smoke is bigger than the signal from the flame, as it were, if the flame is the mutation-carrying cells, which in any case are almost impossible to detect this early. So to summarize, for the biology, hard problem, we very much look at the host response, and to do that, we're really interested in the gene expression changes across the genome from this enormously complex milieu. And to do that, we look at cell-free DNA, in which we look at fragmentation patterns and all we can learn from that. We look at methylation marks of several different kinds. We also look at RNA, because you can get some insight into the transcriptional state, but a lot of RNA is degraded in the blood, which is a challenge. We look at microRNA around regulatory questions. We look at protein, because for some indications that's really important. So it's a very, very comprehensive, holistic analysis. So that sort of brings me on to why AI, and why is this an area? AI is becoming so hyped. I feel like if we were fundraising, just sticking AI on a deck would be exactly the reason. But really now it's more about execution, and it's really, I want to get across why AI is an important, or really should say machine learning, an important part of what we're doing. So I think one of the interesting things as people use the AI buzzwords is really to think about what it's good at and why. And one of the great things I think, when you boil it down, is machine learning really, where it's really been used really well, other than reinforcement learning, like DeepMind are doing a great job of, and in some other settings, really what's working well at the moment is labeled data leading to binary classification. So things like, it's why image recognition is really good. There's lots of examples of that, and that's quite analogous to the problem we're working on. So we want to detect cancer. We've got lots of samples of cancer and lots of non-cancer. It's actually, it's more complicated than that because of all the subpopulations and things, but that's effectively what we're doing. So that's good. We're aligning with where machine learning has performed well. And why is machine learning good? Well, one, you've got an enormous combinatorial complexity, at least potentially, and that leads you to the ability to approximate a function, which is really what machine learning is doing, in an iterative, almost Darwinian way, where you can try out lots of settings of parameters and tweak them in an iterative process. That's really why AI is good. Kind of, for my next slightly geeky question, as I get fascinated by combinatorial complexity, as an analogy, and it's nowhere near as complex as a neural network. For instance, with a QR code, when I first saw those, I thought, how could you possibly encode all of the different kinds of shampoo and flights we could check into, as I discovered on EasyJet this morning, even takes their QR code for their boarding pass. How could you do that? But do you know what the combinatorial complexity of a QR code would be? So it's a 25 by 25 pixel grid. Any quick mathematicians in the audience? So it's basically base 2 computing, right? It's black or white, so it's binary. So with 625 squares, it's 2 to the 625, which is just a colossal number, which to the base 10 is about 10 to the 188, which, last question, if anyone knows how many atoms there are in the universe, best guess, 10 to the 82. So it's a whole googol, that is one with 100 zeros, bigger than the number of the atoms in the universe, just on a QR code that we take for granted. And then if you think of a neural net, good-sized neural net could have 100 million parameters, each of which can take on many, many more than 2 varietal values, right? So the combinatorial complexity is so ludicrous. It shows you why you can consistently learn incredibly complex functions which take account of a very, very complicated set of input data, provided you have enough input data, which is always the challenge, especially in health. Okay. So really, this is the point. Only AI could really find patterns in data sets this big and with this many moving dimensions. Accepting that, and this is a lot of what Freenome's had to do in terms of innovations, how do you do that in very small data sets? Ideally, you'd have hundreds of millions of patients. Or, in fact, as someone said, with 100 billion plus independent data points, we would really want 30 billion or more patients, which, last time I counted, we haven't even reached yet as an expanding planet. So that's a lot of why we're doing AI. And then the other bit I'd like to focus, just as we wrap up, is really thinking about time series AI. So another thing that machine learning is very good at is understanding change through time. And there's lots of examples of good time prediction. And it's getting better and better. So models like LSTM, various recurrent neural network models can be applied to that, as well as even now convolutional neural network architectures with dilated causal convolutions. You can get higher and higher hierarchies where you can actually see quite a lot of time steps. And not to say, about specific models that we're using, but certainly the idea of a feedback loop and feeding back in EMR data round and round to get better and better tests so that we're on an opposite trajectory to those tests I showed at the start. And the encouraging thing is, even on our very early experiments this year, we really are seeing that more and more data thrown in this feedback loop thinking really increases our performance. So, it's a long way off for anyone in the space, but I do think that with this kind of thinking and feeding in more and more data through time in a live system with hospital partners, which we're working with closely, and we're very happy to hear from others, especially in Europe, actually, if people would like to work together on these kind of questions. We do see that the performance gets better and better, and so iterating towards something where a world in which an individual is being sort of annually sequenced, and we build up that very, very clear longitudinal understanding of that person, and a very clear understanding of what does normal look like for them, and therefore when a deviation from normal occurs, what does that look like? And I do think we can get into tests in the sort of high 90s on sensitivity specificity, if not even asymptoting towards perfect pickup, albeit that's a long way off for everyone. And then even going into the future and working more with our pharma partners, what we're really excited about is actually mining all of those insights from those huge data sets that you get from screening. And they really are bigger than almost anywhere else you would get in healthcare, even, logs and logs bigger than even a very large clinical trial, as you have a lot of patients coming through. Because, for instance, 100 million people in the US alone should be getting screened for colorectal cancer. So it's just a different size of health data than we've really ever seen before. And we think that working with our pharma partners and applying our machine learning to really understand those data sets properly, we can really be in an excellent position to mine for much better pathway analysis in a really unbiased way without requiring hypothesis, and then really getting heavily into AI-driven discovery with the benefit of all that and combination intelligence. So for instance, there's 1,000 trials now running roughly in combination for IO, so for PD-1 mainly. And we think that, capturing all of that data and the feedback and the outcomes and reinforcing that feedback cycle will really give an idea as to what combinations should be chosen when, including neoadjuvant treatment with IO. So that was all I intended to cover. Really happy to take, I think I've got about 3 minutes for questions, or I can also stand outside and if people want to chat more about stuff.
Brilliant. Thank you very much, Charles. Can we have a round of applause, please? Thank you. So we're just going to field a couple of questions. Whilst we're doing that, there are 5, 6, some hoggers over here, seats free. So do just kind of skirt on if you want to sit down whilst we're taking questions. So I've got a couple of questions, but I'd like to just take some from the audience. Try and take 2 at the same time. So this gentleman put his hand up first, and then this lady here. Okay,
Hello. What's basically the cost of doing one of these diagnoses?
Sure. So, sorry.
Oh, I should ask already? Okay. This morning it was also about how to manage your data. You're talking about huge amount of data. How do you get it all in place? Is it structured? Is it already in the same way it's organized? Or you have to do that yourself?
Right.
Can you handle remembering this?
I can't promise. I'm going to try. I got up at 5 this morning for the 4th time in a row. So, yes, I'll try. I'll do the cost. We're not public yet about what the cost will be, but it will be in the hundreds of dollars most likely. And the sort of cost comps I can give you are, for instance, the current non-invasive colorectal test is Exact Sciences, which is about $500. And so I think the market has already said what it will sort of bear. I mean, our goal is really, I think, in the longer run to probably be less than that, but who knows about timing. And ultimately, I think also we want to do multi-cancer as well. But it is about doing things stepwise and not racing out with the wrong thing. And then, sorry, the second question. Yes, data. So far, as I put on the slide there, we've got about 45, maybe 50 now. Great, clinical institutes we work with. What we've really seen is a huge variability in data. So it's all structured, but the metadata fields could be anything from like 3 columns, very, very literally like a binary classification kind of a question, right through to more recently we've been pushing really hard for getting hundreds of columns deep in terms of really deep metadata, all structured again. And then from our prospective studies, which we're doing now, they're very, very, very well controlled for data. So it's really, if there's not 100% of everything we need, the patient can't be admitted into the trial, really. So it's all structured. It's very potholed retrospective data, but prospectively, and as we go into sort of live rollout phases, then we'll be much more. It'll be 100% sort of as a QC, really.
Brilliant. And if anyone has a question that's a tweet long, You're welcome to answer in the last 45 seconds. Oh, everyone's too nervous by that sort of attempt. Sorry, I've scared you now. Well, thank you very much, Charles. I have to say that having looked on your website, you've got absolutely gorgeous branding. So whoever did your design has somehow made something that's quite biomedically complex.
Yes.
Very beautiful. So
Our marketing team, I will pass on. They will be very pleased, and I agree.
I mean, thank you very much for a very kind of sound and appropriate presentation. Can we have a round of applause for Charles?
Thanks.